Treatment is important for stress fracture, stress injury, and it's very important to understand that treatment is mostly rest, but it isn't just rest. In fact, the most important element of rest is, of course, relative. And what one needs to do is advise extreme differences between the activities which brought on the pain and the new advised activities. So if someone is simply walking around and not doing any sort of sport, then what you need to do is put that patient on either crutches or in a boot, because the relative difference must be obvious. Runners, in most cases, simply need to stop running, and we'll get into the more detail about this later. Medications aren't very useful, but acetaminophen can be used for pain control. We are trying to avoid using non-steroidal anti-inflammatory drugs, since there is some new data demonstrating bone healing retardation. These anti-inflammatories may prevent your patient's stress fracture from healing, so avoid those. Rehabilitation is a complex area, but stretching and strengthening of the supporting structure seems to help increase the activity gradually, and this is the most successful return to normal activities. There is some decent evidence to support the use of pneumatic compression devices or other shock-absorbing, stress-relieving measures, and compression boots can be used. The topic of cross-training will be covered in detail a little bit later, but one of the many benefits of cross-training is, of course, cardiovascular fitness. Lastly, there is a variety of conditions, stress fracture locations, which can be high-risk areas, and in many cases these are prone to not healing, and surgery is required. As I mentioned, I'm showing a handful of pills in one slide because this is not what is usually beneficial. Tylenol, acetaminophen, paracetamol, depending on which country you're living in, it can be useful. Vitamin D supplementation can be useful, but otherwise there are no good medications for stress injury. As I mentioned, rehabilitation interventions are complex and beyond the scope of this talk, but range of motion exercises are essential. Muscle strengthening exercises can be useful, body awareness and balance training, moving on to more functional training, and of course lastly, sport-specific or activity-specific training is beneficial for the patient. Young sport medicine physicians are always interested in cookie cutter type guidelines, but this is the best I can come up with on this next conservative modified stress or activity guideline, and that is metatarsals tend to heal a little more quickly than other bones at perhaps 6 to 8 weeks of rest or modified rest. The tibia and fibula take approximately 8 to 10 weeks, and then there's a wide range from 8 to 12 weeks for tarsal, femoral, and spinal stress fractures. The key in these situations is to keep your patients active, and there's a slide showing bracing. I don't think that any evidence is available to suggest that bracing will either prevent or treat stress fractures. Important is the concept of cross-training. I don't think we can ever under-emphasize the importance of a psychosocial impact of telling a patient you can't run, you can't jump, you can't whatever for X number of weeks. It's a huge impact for athletes to be not doing their sport. So we do our best to keep the athlete connected to their sport and their teammates in as many ways as we possibly can without impairing healing. One of the things is to optimize the extent of non-threatening activities, such as choreography in ballet and gymnastics. This injury, bone stress injury, rest period can give the athlete time to focus on something they wouldn't normally be focusing so heavily on, such as choreography. Comparative activities, as I've called them, are activities which mimic, if you will, the regular sport, regular activity. So runners can, in fact, do deep water running with or without a buoyancy belt. There are reduced gravity, anti-gravity type treadmills, which lift the patient off of the treadmill and therefore produce a little bit less force. So one needs to be, as a sport medicine physician, one needs to be creative and allowing the athlete to be active, but you need to be very clear with your boundaries for both athlete and coach. Always important to be positive and certainly arrange follow-up at crucial benchmarks. So if you expect a patient to be possibly ready to return to a component of their sport at a certain number of weeks, make sure they follow up. Going to show a slide here of a bone scan of a chest and spine, and you can see there's a rib lesion there. This is in fact a stress fracture in a golfer. So golfers and rowers will not terribly uncommonly get these with repetitive overuse. And the last X-ray slide here demonstrates that in fact upper extremities can also be involved. This is a stress fracture of the radial shaft in a cheerleader that was, of course, doing considerable upper extremity loading. Prevention, as we commonly describe, is both primary and secondary. Primary as meaning that the problem has never been present, and secondary, of course, means that there has been a situation experienced, a diagnosis made, and we're trying to prevent this diagnosis from ever returning. So there are many modifiable risk factors, and it's important to address these. And one of the ways is to look at the specific sport and the specific training patterns and avoid these, change these up. Adequate rest, as mentioned, is key for prevention as well as treatment. The dietary intake is important, energy values, and there is a less of an emphasis perhaps on calcium and more on vitamin D, according to most recent research. One can easily measure serum 25 hydroxyvitamin D in the blood, and the target value is really above 50 nanomoles per liter. This should be measured after 3 months of supplementation, which can range according to the specific case, anywhere from 800 to 2,000 international units daily. One should look at any abnormal biomechanics and consider shock-absorbing inserts. I want to briefly mention complications of stress fractures. As mentioned already, these can progress to complete fractures, which are certainly problematic in many cases. The development of avascular necrosis can occur, and either delayed union or actual non-union can occur. There are high-risk stress fracture areas, as mentioned before, and these specifically are the supralateral femoral neck, the sesamoids, the medial malleolus, the talus, the navicular, and the fifth metatarsal base. Often these areas are high risk because of their challenged blood supply. So the take-home message slide here is important because it demonstrates that this family probably gets some good sunshine They're out exercising, they're being active, they're doing it in a likely healthy way, they're probably consistent, and they're not going to get a stress fracture. The next slide demonstrates an algorithm provided by the American Academy of Family Practice, and it's a good summary of how we move through the progression of identifying stress fracture, and it quite rightly suggests not jumping into imaging for all patients. Thank you.